unexpected pleasure. This is good. As Geoff says, I'm a cancer doctor from Oxford. I'm interested in how we personalise the treatment that we deliver, and I'm interested in health policy, so how we connect the two in some way. And I think working closely with Lionel Tarasenko, it's impossible not to have an entrepreneurial streak coming through in that way. In fact, when we built a new institute in Oxford, a really important component of that was the new Institute of Biomedical Engineering. So we're immediately adjacent to each other in this large sort of building that was custom made for us. So for me, it's about personalised medicine, and it's using every trick that we can in terms of technical know-how, so that I can deliver the best treatment for the individual patient that I see sitting across the consultatory desk for me. And although I run large trials, I do trials in populations of patients. What we have to do is to collapse that data and information down to the individual, and that's us understanding the genetic background of disease, how the host metabolizes and deals with drug. So there's a whole set of genetics around that, how the tumour behaves, how the host responds to treatment. Remember, as a cancer doctor, many of the drugs that I use have got narrow therapeutic ratios, small increase in dose, big increase in toxicity. So so we said that, cogito ergo sum, I think, therefore I am. The motto for an oncologist is veneno ergo sum, I poison, therefore I am. And that's why we exist. Because if we get the drug dose wrong by just a wee bit, then the casualty rate goes up sort of hugely. So I'm right in the cusp of benefit and harm. And therefore, anything that I can do to deliver that better is important. So there's something around modern technology that's advancing, bringing rapid DNA sequencing to the bedside, and you've had examples of that this morning and how that moves forward. I think imaging devices, unquestionably, we're getting better at the anatomic localization of cancer, how we define tumour burden, and how we look at response to treatment, and innovations such as PET technology, which allows us to use clever molecular dyes to shot the cancer, is really sort of moving things forward, helping us hugely that way. Credible technical innovations in the surgical side, with robotic surgery, Adadarzi and all that stuff. Credible innovations in how we deliver radiation therapy in terms of focusing and shaping the beams of radiation treatment so that we zap the cancer and not normal tissue. So things moving forward significantly in that way. But perhaps the biggest, the most important innovative change that we'd be involved in is how we communicate bits of information and how we keep the patient in touch with what we're doing. So Lionel will, when Professor Lionel Tarasenko gives his talk at the end in terms of how he aims to personalise delivery of care using things like mobile phone technology, I'm absolutely fascinated by that. And we ran a project in which we monitored patients on chemotherapy. Every day they would fill in their mobile phone what toxicity they were having, and we would be able to give advice as to how we would manage that, how they would be able to respond to make the drug much more safe. So by testing, by driving another attempt at personalising the care we deliver through quality dissemination of information to an individual, I'd like to see what I could do to take that to the developing world. By 2020, 70% of all new cancer cases will be in low-income countries. You think cancer is a disease of the rich, the north, the industrialised. It's not. It's a disease of the developing world, driven by virus, driven by lifestyle changes, driven by tobacco. There are more deaths from cancer than AIDS, tuberculosis, malaria combined. So this is a huge chronic disease burden. And those countries which will be least able to deal with it are those which will be most affected. And therefore, we need to think about innovative technological solutions as to how I can manage cancer in rural India, in rural Africa. And I know that Rwanda has better mobile phone connectivity than the Cotswolds of England. Going home in the train, they don't work. So how can we adapt the high-fidelity technology that people in this room are developing for what I most want to do, which is the global cancer burden and what we can do in low-income countries? Can you come up with new screening handheld gadgets? So there are ways that I could screen for breast cancer in churches in Ghana on a Sunday afternoon, rather than the complexities of mammography, etc., etc. And does every modern innovation in scanning, does it always mean that it's going to cost $10 million to build forward? Can you build as cheap clockwork radiotherapy machines? I made that up as I go along. But there's a sort of sense that we need to drive technological innovation in terms of improving the quality of the information that we get, but in terms of driving costs down so I can take it to the developing world. So I absolutely wed to the concept of us getting out of our bunkers. Lionel was teasing me over lunchtime about he's never met a profession that's more vertically siloed than medicine, and it's true. It's absolutely true, because I never meet a diabetologist, otherwise I would have my elbow in his face, or a cardiologist and I have my boot to his bottom, because we compete with each other. We just don't. We're just not a very cohesive, we're a sort of rather vertical group, and it does take someone like Lionel to integrate laterally and to come up with solutions that allow us to do things that way. This is your key. So if there's one thing you remember about me, apart from my slightly adult talk, I literally just got off the plane from Beijing, and I think my brains are still over Tibet somewhere. When we talk about vertical delivery of healthcare, lateral integration, think about diagonally doing it. That's what I'm going to do. I'm going to think about diagonalizing healthcare in terms of this global cancer burden. So confused and garbled talk, but very happy to answer questions when Geoff moderates the thing later on.
Thanks very much. Now the opening manifesto from our second speaker, Professor Daniel Steenstra, Academy of Engineering Visiting Professor in Innovation at Cranfield.
So the subtitle of what I want to talk about is innovation in the NHS. Normal rules do not apply. I'm one of those hybrids or tribrids or whatever you call them that was hinted at before lunch. I graduated in medicine in Holland, but really escaped quickly to go to Italy to design Ferraris and all sorts of other things. So I lived a long time in industry, in companies such as Jaguar and Ford, doing innovation, design, product design, and so on. Then spent some time in academia in Warwick to help small businesses to get in the healthcare sector. And when I'm not at Cranfield, I actually have a small company in the NHS, Innovations Factory, and we develop and commercialize healthcare technology. So I'm actually embedded in the NHS as well. And that's informed my view. What I really want to do is discuss and present another way of innovation, which is called disruptive innovation, and see how relevant that could be. It was a bit interesting to see Jim's presentation before lunch, because I'm going to put pictures behind the statements that he made. So if you look at the NHS challenges, this is figures we know. On green there, you've got the money that is running out, and this is looking at in blue and red the services that the NHS delivers in the past and in the future. And there's clearly a disconnect there. I think there's a more scary graph, which is this one here, which we can't find real validation, real numbers on. So we got money green, running out, economic crisis, and this is the real need in us. I might keel over tomorrow with a heart attack, and that's the need that is captured in that red line there. So not just what the NHS is delivering today, but what isn't it delivering today and what it should be delivering today. I think the scary thing is nobody can tell us where we are. Are we here or are we there on that curve? Again, putting pictures behind what Jim was saying this morning. We see it in the headlines. This was yesterday. Secretary of State, crisis. This is the statistics behind the Staffordshire inquiry now. It just killed too many people. And this is not an isolated incident, because if you then look at some other figures of other hospitals, Mid-Staffordshire is not an isolated incident at all. So then why is innovation then the way to deal with this crisis? Because efficiency and productivity, doing the stuff that we're doing today better and faster, is actually not going to close that gap. In order to close that gap, we need to innovate. And Schumpeter, an Austrian economist in last century, made the direct link between economic crisis and innovation. Now, politicians have recognized that. This is Vince Cable saying, the way we deal with this economic crisis is innovation. And it's us, innovators in industry and academia, that are the key to this. What does it mean for the NHS? Again, I was pleased to be in tune with Jim in the department. I'm really a shop floor innovator. He's obviously at a different level, but words are the same thing. Transforming the NHS through innovation. And it's actually getting stuff out of hospitals, getting it much closer to patients, and thinking about how do we prevent conditions in the first place. So that's the direction of innovation. The story so far, looking at the brief that Catherine gave me, what's happened in the past and what's going on today, I had to, it's a bit early for the Christmas spirit, but I had to sort of refer to the ghost of innovation past and present, and we know this. This is data that we know. NHS is a late and slow adopter of medical technology, but what it means is this. Well, we actually have, and my company have added to this big warehouse of lots of innovative ideas, and it's there. It's thousands of things that could have a direct impact on the quality of life, but we, businesses, we academia, actually keep on adding to the warehouse. It's not being used. Now, I think, and I won't go into detail because I haven't got the time, but I think there's about 9 reasons why this is the case. I think we as consumers behave differently when we become patients. I think innovation is extremely hard. In the NHS, it's harder than anywhere else. I think the intellectual property has got a part to play in this as well. And the NHS is not Apple, it's a service organisation. And we shouldn't be treated as an Apple or a Virgin either. But I think there's very good reasons why the NHS has developed the way it has. Now, this is a scary picture, and I hope you don't take this too bad, but I think if we don't do something with this, this is the ghost of the NHS in the future. So this is a real crisis. We need to do something right now. If you then look at the types of innovation, again, Schumpeter last century recognized 2 types of innovation. One type is incremental, so we just do a car that's a little bit faster or a little bit lighter. He also recognized the radical stuff, so we don't do cars, we do Sinclair C5s. I think what he missed then 50 years ago, but now academics in the States have recognized, is disruption. This is a guy called Clayton Christensen, Harvard Business School, and he's saying if you look at our performance requirements as customers, if you start off with the least demanding customer, the mid-range and the most demanding customer, traditionally technology starts somewhere there in the middle and it goes up. And these things, you all have them, are excellent examples. This thing is far more intelligent than I am and I don't use all of its functions. So it's actually gone beyond the most demanding customers. So what Christensen then saying, once that happens to a technology, it is then the opportunity for a simple technology to come into the market and actually attract the least demanding customers. And I think that is the way forward for the NHS. Examples of companies that have sort of grown based on this philosophy are Sony, IBM, Virgin, and so on. So it's quite an established theory, but that's all it is for the time being. It's just a business school theory, and it's our challenge to make this theory real. So far, the theory has been described for the US healthcare system, and clearly it is relevant, but the UK healthcare system is totally different, so you can't just copy it, you need to change things. And in typical, I shouldn't say that too loud, business school fashion, it lacks real operational tools, techniques. How do you make this happen? But I feel it's the right thing to do. Companies such as Circle have recognized this as well. I think Christensen's book has now got an award of the NHS. And it's actually about affordable products and services and also getting stuff out of hospitals into the community. This, by the way, is an example. This is an NHS consultant anaesthetist, 20 years ago came up with this idea. And this is diagnosing anemia, low hemoglobin, at point of care. Instead of you going to a GP, taking a blood sample and waiting days or weeks for a result, you can get the result in 10 seconds. So with lots and lots of advantages. There's actually real examples where disruption could work to manage cost and increase outcomes. How do you do it? And this is a little bit of a plug for Cranfield, because what we're going to do on the 1st of December is launch a practical initiative, demonstrate tools and techniques whereby you can actually bring about more disruption. And it actually means it's working together with clinicians, patients, and engineers, and so on. So I would all invite you to come to Cranfield. But the role of the engineers, as I said, I'm not an engineer. If anything, I don't know what I am, a designer or still doctor. But I think engineers have a crucial part to play in this new reality of innovation, especially when you talk about disruption, because patients can't tell you. I can tell Jackie I want a faster car. I can tell the NHS what a 10% better healthcare experience, what that looks like. So as a patient, I need to be involved in this throughout the whole process. That means as engineers, we need to understand how we can work with patients, how we can work with doctors, how we can work with nurses, and how we can work with entrepreneurs and so on. It sort of redefines, I think, what we as engineers have to do. It also understands how do we simplify technology. When is technology good enough to give us information that we can base a clinical decision on? And I think also engineers need to develop or be aware of entrepreneurial skills. You know, at some point in an innovation, it's only an innovation if you're making money from it. So engineers need to be very much instrumental in that new reality. Hopefully I've gone full circle in saying the NHS is experiencing real challenges. I think the role of engineers is critical in this, and there's actually another type of innovation that is getting stuff much closer to the patients, but it has to be driven by patients, and it's engineers that need to integrate this new type of innovation. Thank you very much.
Thanks very much, Dan. You're quite possibly the only person in the room who qualified in medicine and then went on to design cars. The third brief manifesto comes from Dr. Susan Ludgate, Clinical Director of the MHRA, Medicines and Healthcare Products Regulatory Agency.
You got it right. Good afternoon. I will be brief because I realise that I'm the big bad wolf in all this. As regulator, we are damned if we do and damned if we don't. On one hand, I think you see us as stopping innovation coming to market, and on the other hand, we really get a lot of attention if something goes wrong and patients die, and why haven't we regulated better? Why haven't we taken it off the market? So we can't win. So if we start from there, that makes it easy. I think the first thing to say is that this is made all the more difficult by the fact that the devices regulations were actually not brought in the interests of public health. They were brought in to produce a level playing field for manufacturers, to make it easy for them to enter into the European market in each country with similar standards across the EU. But as time has gone on, obviously the healthcare agenda has grown, and we've had to adapt these regulations to make them much more patient-focused and patient-orientated. And we have, as regulators, I hope, tried to do that. I think what has struck me over the last, particularly 18 months, 2 years, is that we have seen about a 70% increase in innovations coming from the health service, not from manufacturers, but people working in the health service, with really some great ideas and coming and needing help. And we have tried to help. We have set up a series of meetings. You can come and meet with us. You can talk through your issues. It can be really from very simple ideas in your mind to the more complex and the more well thought through. But for example, the other day we had a cardiac surgeon who came in and said, "Sue, I want to lie on the beach in California, but I want to monitor my patients in the UK so that I can phone up and say, give them a shot of this or a little bit of that." And we worked through how you would do something like this, not in any detail, but how you would go around trying to develop something like that. So we're very open to talk through development. If we can be of any help in helping you design trials or inputting into that, we're very happy to do that, to talk about parameters, your approach, even perhaps the centres that you might like to concentrate on or where we know there's particular interest. Whether you need your trial authorised by us at this stage or whether you're not going commercial, and it doesn't need to come to us yet. So hopefully we've set up a mechanism where we're very happy to talk to you and to try and get you through these regulatory hoops and get onto the market if that's what you want. There's also been some movement on the ethics committee front to try and help by setting up, first of all, specialised ethics committees that are dedicated to devices so that they actually know what they're talking about and know what to recognise, and we work very closely together. And that's been successful, and nowadays, as you probably all know, you can make one application through IRAS, again to try and facilitate all the mechanisms and hoops you need to go through so that you only have to write out your application once. I think it is terribly important, however, that the message that I want you to take home from me is that I do not believe as a regulator we can work in isolation. It's just no longer tenable. We have to work, if we're going to move forward and we're going to innovate, we have to work with scientists, with clinicians, with manufacturers, in this sort of close alliance, because it's only, I think, by doing that and by us trying to help you through the regulatory hoops and what you can do and can't do, that we can actually move forward. We recently, 10 days ago, for example, had a very good workshop at MHRA where we were looking at orthopedic hip implants, because there's been a lot of problems, as you know, about these, and how can we go through from the early design right through to the patient in the best interests of patient safety, all working together. And I think it was successful because we all recognised that we all had a part to play. So my message is we must work together. You must use us, not see us as the big bad wolf that's going to say no, but a facilitator to take you through the process. And if you have ideas or innovations or things, come and talk to us. So thank you very much.
Well, thanks very much, all three of you there. Three very distinctive viewpoints. Now, look. Well, thanks very much, all three of you there. Three very distinctive viewpoints. Now, look, I want to play this largely by the sort of ideas that you raised, but before we come on to hear what it is you want to challenge or question or query the speakers about, can we start off with something that Daniel said, which struck me as perhaps getting to the core of the problem, if there is a problem. It was, I think you flashed up on the screen there, the NHS, a late and slow adapter of medical technology. Now, if you're right about that, and of course other people may have different views about it, if you're right about that, that does suggest there is a problem. Let's see what the other two members of the panel think. Susan, that charge, a late and slow adapter of medical technology, do you think that's a fair comment?
I think there's two sides to this. You get the surgeons and the innovators that you actually can't keep down, that keep having these brilliant ideas, and why am I stopping and bringing it to market? Yes, I think on the whole it's true, though. I think we are very slow to take up new technologies. It's always blamed on regulation, but I don't think it's a regulatory thing. I think it's a cultural thing, and I think it's a financial thing.
A cultural thing in terms, what, respect to the culture of doctors or the culture of the health service in general, or? I
think the culture of many doctors, actually. A lot of doctors are very happy with what they do, and they don't want to take up new ideas and new devices that they don't know anything about. We see this quite often, actually.
Well, let's see what the doctor on your left thinks. So, is it a fair charge, do you think?
No, I think it's too big of an overstatement, and I think that if the innovation is big and if it works and if it's fantastic, with big margins of improvement, it will be taken up rapidly. Whereas if the benefits are sort of, in the borderline and it's relatively small, then it takes a while to trickle through because people are naturally sceptical. They require collection of more evidence. So if it's a big slam, bang, dunk, goal, big sort of thing, it will roll out very, very quickly, if not more slowly. So I think different rates for the sort of, the depth and size of the intervention. I think what is true is that we're not very good at the experiments that we do, randomized controlled trials. They take ages and ages and ages. And I think we need to think of better mechanisms for introducing new innovations, using perhaps different tools than experiments that might take 5 to 7 years And then with a sort of subsequent trickle-down type thing, that could be 10 years, which is the sort of thing that Daniel was talking about. So mechanistically, we need to be able to respond to innovation better than big, complex, expensive randomized trials.
I'll come back to you in a minute, Daniel. Susan, you wanted to say something else?
I agree with that. One of the problems with devices is lack of evidence. Yeah. We see it at NICE committees, the Medical Technology Advisory Committee, where we're looking at bringing new devices that stand out to market quickly. And so I don't quite agree with you, because we see some very good technologies there that one is constantly surprised have not come to market quicker, but they haven't been taken up. But it is lack of evidence. And I think this is one of the real problems we have. I entirely agree. Randomized controlled trials are a no-no. We've got to do it better, but we have to generate that evidence, and it's how to do that in a way that science and doctors believe.
Okay, back to you then, Daniel. Go back to your original statement. I mean, can you justify it in terms of sort of saying, well, look, this is the way it is, this is the way it should be?
My arrogant answer is I don't need to justify it, because it was Derek Wanless that actually demonstrated it. But I can explain why I think it happened, because this sounds a weird, absurd example, but if I design a stethoscope with sort of pink tubing, that might appeal to some doctors and maybe more doctors in Holland than anywhere else. But I'm not asking this doctor to change his or her processes. If I stick a Bluetooth chip in the stethoscope, and that enables the doctor to listen to somebody's heart, but then consult with somebody on the beach in California to say what's going on with this patient, I then expect them to change their processes and change maybe the organizational structure of payment as well. That means, I think simplistically, one of the issues is that we technologists design technology in isolation without designing the processes and the organizational change that has to come with it. So we give the market, the NHS, a new product, and the NHS has to work out by itself how to use it. And that might take days, weeks, or years. So I think it's actually a fundamental design challenge, is how do we integrate it, design with end users, patients, and doctors to avoid this huge adoption gap.
I mean, one of the troubles seems to be that one of the statements you put up there was that the NHS is an innovator, is not an innovator, but a service provider. And is it, as long as service provision is its main function, which it clearly is, innovation is always going to have a second place, isn't it?
Again, the statement is that the NHS as a structure is not like Apple. There's lots of clinicians in the NHS, as we've seen today, that are innovators. But as a structure is not geared, it's not particularly rewarding these innovators. But I think it can move to that sort of situation where the NHS, instead of buying in technology that is totally ready, actually gets into a proactive role as an organization and say, let's commission new technologies in home care stuff and get involved as an organization in conceptual development as well. So I think as an organization it can change.
And you too foresee that?
Yeah, I was going to challenge Daniel again. I know exactly what you mean, but I think things have really changed. We're now spending £1 billion a year on R&D. £1 billion a year in R&D. So that's, okay, it's only just about 1% of our total budget, but nevertheless we've been sort of building up towards that. And if I use cancerology as an example, when I was a kid, maybe 10, 15 years ago, 1% of cancer patients were in clinical trials. It's now 15%, absolutely world leading. It's still in the States, it's less than 2%. So there's a whole innovative culture about engaging with patients, with doctors, with industry, of driving new medicines, new gadgets, new devices forward in that way. And the proof of the pudding is that that investment has paid off. And there's no doubt that that will lead to a more rapid introduction of novel technologies. And we would also argue that patients who are treated in clinical trials, in centres who support clinical trials, that's a quality hallmark, if you like, of better outcomes and all the rest of it. So I think if I look at other health services around the world, in terms of our R&D, people are looking at us amazed and delighted by the progress we've made, probably in the past 10 years.
Susan, I mean, do you see a conflict between the notion of the NHS as an organisation which is fundamentally a service provider, but it is at the same time trying to innovate, or can you see the two working together quite satisfactorily?
No, I think the two can work together very well indeed. I think they're complementary. Indeed, I think to have a good innovation push can make doctors more excited. I think that it can make the whole practice of medicine more exciting. I see the two going hand in hand.
But you did concede just now that there's something about the culture which doesn't actually drive innovation forward, which is more likely to break it than drive it. And I'm not quite clear what sort of change structurally it would require in the NHS in order to bring about the kind of environment which you would regard as more user-friendly to the innovator.
Okay, if I could answer that, and that's really, I think, what Jim said as well in the morning, that the NHS is a top-down structure. But in nature, what we want as innovators is lateral connection. So if you take, for example, a good practice that works in Oxford, it doesn't mean that, Glasgow is going to adopt that easily. You still have to sell it, present it, and so on and so on. We got a wonderful example of home dialysis systems that work a treat in Liverpool. But, we can't roll it out over the rest of the UK because the evidence base and lots of excuses. So, although we see lots of good R&D local practices, the issue is scaling up and lateral connections. And that is just not, that's a structural issue. I think I was very, very pleased that Jim actually recognised that. Hopefully it is coming out in the innovation review, because the stuff that you're doing needs to be spread out quickly.
I agree.
Yeah.
Interesting point, though. I agree in terms of the bottom-up thing. And the idea is, if somebody gets an idea, but they don't have the necessary local package to turn that idea into a protocol or a trial or whatever, that sort of thing, it's how does the innovator get access to the expertise to turn that bright idea into the sort of experiment that will prove it, that will gather the data to convince in that way. And I think we're better at signposting where you might go for that. So the district general hospitals and all the rest of it have opportunities to network in. There's actually signposts that would say, go to hospital X or Y, or go to unit A, B or C to get the sort of advice that you need to turn the idea into something that would be workable through.
Well, I think we are getting better at that. We now offer that sort of service. But I don't know if it's universal, but something that we see very often is good ideas proven clinically within maybe one hospital setting. No money to take it forward from that point. Where do you go for partnership? They're looking for industry partnership. And that's where we see often the gap. They don't know where to go or who to talk to, and very often are met with a lot of rebuffs. Now, that may just be a slightly skewed view. I don't know if that's something that you've come across.
Is that something that you say that as a sort of service, a help that you can already offer?
We can help them get through the system and where to go to carry out their trials.
Yes.
But as regulator, we cannot say, look, you go and speak to X, or, well, we can indicate it, but these are the companies you might like to go and talk to.
Yes,
but we can't actually set that up as our regulatory function.
Yes.
And we find that is often the block.
Yes. What about people in the room? How do people in the room take the sort of central proposition that we had here, this late and slow adapter of medical technology, and what one can do about it? Yes, there's a hand there. As usual, your name first, please.
Fine, thank you.
Well, Chris Ramsden, Chartered Society of Designers, but I'll answer this as possibly Medilink as well. In that, one of the problems, and also as someone who's worked for many years in healthcare, both in NHS and private healthcare as well, in terms of finding companies to get engaged with, one of the big problems NHS and health often has is it loves reinventing wheels and built, as we already heard earlier this morning, adding more and more layers on. Medilinks was set up specifically to match up clinicians, academics with industry partners. If it's a larger company, there's a partnership with it, the Association of British Healthcare Industries and other networks. They're in existence, have been there since 1994, so that network's set up. Sadly, we don't tend to learn from our mistakes as well. The NHS and healthcare is a very odd culture. It's a country, as we know it. It's a different mindset. And innovation has often been inappropriately named innovation, and they're trying to do it to the NHS by people who don't understand the culture of the NHS. And the NHS is great at squashing everything like that. Now, something which I tried many years back, which was quite successful, was actually running a design department as part of one of my clinical departments. So it was actually part of a clinical service, but you actually had designers who were used to working with real innovation, with experience outside of health, who could instantly go to a patient bedside, work with a clinician, sketch up, develop up a concept idea, market test it, market proof it, and you're talking about days, because that's how the rest of the world work, like the car industry. You'll get a design concept, sketched up, rough ideas within a couple of days, and a rough costing. That ran for about 6 years, and as Dan said, horizontal communications, the phrase was, it became known as the no-prat zone, because healthcare, as hopefully we all know as well, is more unionised in the shipyards. So the concept of getting an occupational therapist to speak to a physiotherapist in the same room is quite a major achievement. Sorry, I'm being a bit cynical here, but it's called my department cynical engineering, not clinical engineering. But it did become an anonymous venue for exchanging ideas, because things would not be held against people. It was totally interdisciplinary, and it worked at exactly the same design practice that other industries use. And it was tremendously successful. It didn't cost anything, it generated income. Now, sadly, that is a model that hasn't been followed up anywhere as far as I'm aware. But the key thing is that instead of people being parachuted in, this is where some of the innovation hub models haven't worked, and engaging some other organisations hasn't worked. People think, it's a great idea, we'll do it to the NHS. You can't. You've got to understand the culture, you've got to challenge the right people. It's a two-way learning thing, but it really takes off very, very quickly and generates lots of appropriate innovation, not just innovation for the annual report.
Responses to that from anyone?
No, I think the point's well made, and I think all of us have good examples of that as we sort of come up through the various ranks. There is an interesting thing, and I hadn't really thought about it until you mentioned about this balance between bottom up and top down. In that you're right. I mean, we've become used to waiting for a call for money coming from the top, from the centre, that we apply for. We succeed or we don't, and those of us who are academics spend our whole life going back and forward with grants. What we don't have are often our local pools of money which are carved out, or which are created for local innovation within DGHs or within clusters of practices, to actually put a bit of the budget aside deliberately for the sort of actually local department that you talked about, that could be to do with innovation or adaptive design or whatever it might be. That we're always waiting for something coming down from above as the only way of driving forward, which is slow, which is stultifying, which is often directed in specific programmatic ways, and might miss out what you're doing. So there's something interesting about, would an innovative trust hospital chief executive create a small pool of money or pocket locally, rather than always waiting for it to filter down from above, with things happening that way? Sort of interesting, actually.
Yeah, if I can say something, to me it's jigsaw puzzles. I think many of the pieces are in place, but they're not all joined up. And I think I would make a case for the hybrids. And you were one of them this morning, because you might be a vascular surgeon, but you might be at home in a chemical engineering department as much as. And we've seen quite a few examples of people that are cross-disciplinary, that can piece these pieces together by themselves. You then say, can we institutionalize this? Do we actually educate these people? Can we get, like Glasgow School of Art is obviously a wonderful place, because there you get co-education of designers and engineers. And one of the arguments I would make is, can you co-educate engineers with medical doctors? Can you actually, in the formative ages of development at medical school, stick them together so they understand each other? So it's actually bring these pieces together, but actually educate people to work within, more hybrids, basically, with different understanding and different backgrounds.
I saw your hand on. Yes.
Christine Blood, I can boo, so
You won't go on the recording, though.
I just want to say that the model which we had this morning from Leeds, which I think is replicated in Manchester as well, where you have different institutes working together, bringing different skill sets, is a model which I think, if the money goes there, everybody will be wanting to do it that way because money drives the agenda. And where you have a really good department that's well integrated with several different disciplines, the money goes there, then people will run their departments like that.
Yes. Did you want to follow up on that? Yes. Sorry, I'll come back to you in a minute, but since it was your department that's only been talked about.
I just want to comment on two things. One is to Professor Kerr, there is absolutely no doubt that hospitals should put money behind these sort of research projects. And once again, I can beat the drum for Leeds because the Leeds Hospitals Trust Special Fund we have, where we can give grants of up to between £30,000 and £50,000 a year for pump priming pilot projects. And this came into being after people like me and colleagues went to the trustees and said, look, it's the eternal catch-22 position. You can't go to the MRCs and welcomes without the pilot data. Waste of time. In fact, I would say to people, do not waste time writing those large grants. You have to have pilot data, and the trustees now have a pot of money to give people, and this has worked very well. We've had pilot data come out of these, and they have then gone on to get Wellcome and British Heart Foundation grants. I realize I'm a significant minority here, because I keep hearing this thing about the culture of the NHS that stifles everything, and the world came to an end yesterday because of the NHS. It can get quite depressing hearing about one's institution like that all the time. And I realize that we have not portrayed ourselves in the best possible light where innovation and R&D is concerned. But that culture is changing. And what I appeal to the small number of people in this room is that you have to realize that that culture is changing. The way to enable this to take on a sort of an exponential trajectory is that, and now I will allude to, because I have done a number of sabbaticals or short fellowships in the States, is where clinicians have protected time. I do all my thinking, grant writing, innovative, at 2 and 3 in the morning. You cannot expect the next generation to do this. In fact, I have registrars who say, I do not wish to be like Professor Homer. They don't want to do it. They're not going to spend their Saturdays, Sundays, and the 8th day in the week doing it. You have to buy out clinicians' time. And it is a plea for the few clinicians. If they do not do it in their first 5 years of consultancy, you will lose them forever. If they have put in 3 grant applications and got a rejection, they go off and do what every other surgeon does. They go and do private practice. It is a guaranteed source of income.
Yeah.
So get hold of those young people who have the promise, who have the intelligence, and support them. It's been done in the United States. It works. And I've gone there. I've seen it. Somehow that message is not being taken up in this country as avidly as it should be. And that is my plea for the trusts and the NHS here.
Daniel, coming to you, Shivandi obviously thinks that things are improving, with the limitation that, she said, that you've got to give protected time to people to really think. But
I mean, they must, and I also think they are, but it's again local. Innovation is misunderstood. Like Jim said before, people think it's an add-on cost. It's going to cost money. And Leeds is an excellent example where it costs money. It's prepared to invest in this, but very much as a venture capitalist, it would understand that actually there's a payback as well. So I think with the foundation trusts now that are more autonomous and actually could make money available for this, it is then up to us, and I mean clinicians, engineers, to come up with a business case and say, give us this money, but this could be your return on investment. So the communication is not a pink stethoscope. The communication is, here's a potential new concept, but this could be the health economic benefit. So we need to communicate, I think, differently as well. Really understand it's not an upfront investment, it's actually the payback as well.
You were frowning there, Susan.
No, I entirely agree. We've actually, as I said, seen a 70% increase in people coming to us with innovations from the health service over the last year. So something's happening out there, very definitely.
It's a related question is, why is it, and we hear this time and again, good practice, pockets of good practice, almost everything you can imagine exist all over the health service. And very often the complaint is that they've been doing this for 5 years, 10 years, and no one has imitated them. And that pocket of good practice remains just that, a pocket. Why don't good ideas spread more rapidly through the health service? Does anyone have any idea?
I think there No, I think that's changing too. I mean, I think we have a lot of agencies which are trying to promulgate, disseminate, and the old days we had the Modernisation Agency, we had the Centre for Innovation, and they're doing a great job. This isn't in terms of inventive steps, but in terms of how we deliver healthcare, better value, more efficiently, more safely, etc., etc. And I think there's much better communication than ever there was. We use the web. There are all sorts of a variety of different communicative means whereby good practice is disseminated in terms of improving the quality of care that we deliver. I think in those inventive steps that's improving and so on too. So I think, I do think that, you know, the One-List report and all the rest of it was looking backwards, and especially over the past, I would say 5 to 10 years, we've made real steps forward in terms of being able to, you know, innovate, to spread those sort of service improvements much, much more quickly, and some very directed communicative routes and newsletters and all sorts of stuff that allow us to do that. It's better. It's definitely better.
Once again, Susan, you're frowning. Unless I'm misreading your expression.
I think it's pockets again, and I'm sure Mirella will talk about this, that, you know, NICE produces its guidance, but it may or may not be taken up, and it certainly isn't by everyone. There was a very nice bit of work done looking at evidence-based medicine, looking at pivotal trials for various conditions. I mean, randomized controlled trials, powered, etc., where their conclusions were that you would change the practice of medicine. And then they went round and they said, right, to GPs, it was on hypertension and various things. And for about 70%, it didn't change the practice of medicine. So, you know, I don't know the answer to that, but I just think it's interesting.
We're maybe hearing more about NICE later on this afternoon, but I mean, there's a difference between when it comes to drugs as opposed to devices, isn't there? That technology of the device kind, I think, doesn't carry the same sort of obligations when NICE approves it that it does when it's a drug. That in itself, I suppose, is not a help. I wonder why the difference. Well, anyway, we may get onto that later on this afternoon. Anyway,
sorry, can I just add to that? Because I think, you know, it's very innovation is a lifestyle choice, but the nature of the lifestyle choice, it is bloody hard. I think the invention bit is straightforward, and the only innovator that I know that was an inventor is Sir James Dyson. He's, I think, the only person that actually took an invention, invented himself, and actually got the benefit as an innovator. Meaning, sometimes you have to split the two up. Yeah. You got the inventor that invents something, and at some point he or she needs to be able to take over because it's no longer in their interest. They don't, you know, it's not what makes them tick. Yeah. And something else needs to take over to do the blood, the sweat, and the tears. So you're talking about, you know, innovators and inventors are not necessarily the same people.
So someone whose hand was up. Yes, it was yours. No, yes.
Sorry, I'm Lars Sundström from Bristol University, but another thing that I do is I run a thing called the Severn Sidelines for Translational Research, which is several universities working together on translational projects. I want to make a comment about the funding, because we've run an interesting pilot for some of the research councils where, in effect, they devolved the funding to these organizations and actually barred the academics for applying for translational funding to the research council for a number of years. An interesting thing happens when you devolve the funding, is you suddenly become a lot more efficient with the funding. So you don't have to look at a 3-year grant, for example. If it's not going somewhere, if it's your money, you move it around the projects that are more successful. You also start to build partnerships with people to take it forward in a completely different way. You're talking to a company, for example, and you're saying, I don't need your money to do this, but work with us to try and help us design this thing, to get it to a point of proof of concept where you'll take it to the next stage. So I think it's an interesting concept. And I think what it does do is it completely reinforces the concept that it's actually, to get collaborative work going in the way that you're describing, it's very much the way that these things are funded. If we've all got a 3-year grant, then we'll spend the money and we'll put as many overheads as we can on it as a university to try and do that.
I think that's dead interesting, and I sort of seen that work going on in Singapore and elsewhere too, and we've tried it. I mean, the research councils come together and say you can only get this money if you come together as a group, and it's got to work and be joined up and all the rest of it. I wonder a little, and this is me being a centrist now, about devolving all the budget away. I devolve a big chunk of it. And that's just to do with competition and standards. And the worry is that you devolve it away into Nowhere City and being a sort of, golden triangle type sort of snobby rascal now, and we go because the money's being devolved away from the sort of fantastically good and great and fellows of society, all this sort of business and so on. And if you could demonstrate that by doing that you kept up the quality of research, that all the indices of blah 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 were maintained, got no problem with that at all. So maybe there's a halfway house of some centre, but I think it'd be dead interesting to devolve away too and just see what happened. It'd be fun. I agree. Yeah.
Another comment or question of yes, and then one, and then two.
So we've heard some comments about the NHS and not being innovative, but some counterpoint to that. Can I broaden the discussion a little bit? And this question is asked out of complete ignorance on my part. Is there a health system in any country or jurisdiction around the world that is considered to be highly innovative? And is there anything that we can learn from that?
If you were to ask Professor Clayton Christensen of Harvard Business School, he would probably quote Kaiser Permanente. And the only difference why they are innovative is because they have a joint of primary care and hospital care under the same insurance model. That means that if you the NHS makes money from doing interventions that aren't necessarily, but it's just making money from that. In the Kaiser Permanente system, that's engineered out. It's actually choosing the best pathway for a patient. But that is one organization within the US that has a joint of primary care and hospital care system. I mean, I know, for instance, Holland is pretty good in infection control, but, the tax pressure in Holland is much higher than in the UK, so you pay for what you get as well. Again, to me, it's education. How do you communicate to citizens to say, 100% bed occupancy in hospitals is not necessarily a great idea because you don't have the opportunity to do a deep clean. 85% such in Holland is a lot better, but will you spend even more money on the NHS? So there is no best example, but I think it's actually understanding what are how can we learn and merge that? How do we understand our own culture in the NHS and merge all these best practices into the NHS?
Any other offers from?
No, it's a really interesting question, though, because you're right, we're beating ourselves up here for being monolithic and dreadful, and exactly so. I happen to sit on an advisory board for the Dutch government, and I've got to say, I'm continually impressed by the innovation that's going on there at every level of the health service. When we talked about the health service reforms, this is a sort of policy point now. When Cameron came in, he said it was three things. He wanted the doctors to be free to lead the NHS. That's relatively straightforward. He wanted it to be quality-driven. That's relatively complex. And he wanted it to be... So the quality-driven was about, with the previous administration, the health service was measured in waiting times and surrogate endpoints. Cameron wanted to move to things that counted, how long you live, the quality of life, so things that really counted. And the third thing was he wanted to publish that so that citizens would be able to judge locally, nationally, benchmarked, internationally even for cancer, how their service was performing against all. That was it. I mean, that was the health service. Somehow we sort of mugged up their capacity to deliver that. But that's what he wanted to do. That's pretty innovative, actually, because if you look at other health services around the world, the Swedes, the Dutch are moving towards outcome orientation. America, never in a million years. You get these mad league tables in USA Today saying Johns Hopkins is the best hospital in the world, based on who knows what. Really very odd league tables that are made up from nowhere city. If Cameron has his way, if the health service reform bill goes through, this will be a major step forward. I think that within, well, it should have been a term of government, it may not be now, but if we delivered the Cameron, that's what the health service should be about, I think that would have kept us at the edge. I see the Netherlands doing that, I see Sweden doing it, but we could leapfrog them if we could get the machinery of the NHS gathered up to do that. Interesting question, though.
I think it was, yes.
Can I go first, Lyle? Is that okay?
Just
a few observations here, and actually this will build potentially on this last question about where is innovation happening in the world. I will declare Kaiser as an investor in our company, actually, but we'll get to that in a second. So one of the things that's interesting here for me is to talk about what is innovation, and there's a tremendous emphasis, at least historically, on innovation being therapeutic capability. And the innovation that we really need now is about therapeutic capacity, which is a very different thing and not something that historically we've focused on. So therapeutic capacity has to be the name of the game. Notwithstanding the $20 billion that we're going to be short in the UK, what we're facing globally is an enormous surge in demand for affordable health services everywhere. So therapeutic capacity is a huge deal. And therapeutic capacity depends very, very largely on organizational change and organizational leverage. And that is very, very hard to achieve in large monolithic organizations. It depends very largely on your model of competition and your model of incentives. So I would just say I'm personally very skeptical about the idea of the National Health Service engaged in innovation around therapeutic capability, very interested in their ability to innovate around therapeutic capacity because that is the issue of the age, but that's a very challenging problem for them. Around this question of where is it happening most and fastest, India is a country full of amazing innovations in therapeutic capacity. If you look at what Apollo is doing in India, it's astonishing. If you look at tourism from the United States to India to access the very best, highest quality, least cost health services, it's all going to India. So there's pockets around the world. Now, McKinsey's done a study with the World Economic Forum where they've got all kinds of examples of dramatic cost and quality-based innovations going on in India. And I think it's happening because they don't have large, entrenched organizations that find it, of necessity, very, very difficult to change.
Yes, a combination of an absence of a large entrenched organisation plus a very obvious and pressing problem when it comes to sheer numbers. If you've got a technology, you haven't got to make it available to 50 million people, but 500 million people.
Yes, and to be clear here, some of this is about technology, but a lot of this is about human systems. And so, look, the NHS is a system that was invented 50 years ago, and it looks a certain way because of what we knew when we invented it. And people who come to invent and create organizational processes today know a lot more, and they typically invent and build things that look very different. So we're all hailing here the idea of multidisciplinary medicine. If you start from scratch, that's obvious. You just build multidisciplinary medicine. Doing it in the context of, say, Leeds University, where it's a new idea, that's tough, right?
Any comment from that?
No, I take what you say about India. I would say it was the private, not the public sector, and I accept exactly what you say. There's some remarkable examples in cardiovascular medicine, remarkable examples of the eye work that's going on. The public hospital system in India where I work is, okay. So that I understand that point. I also agree with what you say. When we're talking about innovation, I'm talking widely and so on too. And I think that the engineering techniques that you've learned around process redesign, about understanding pathways, we can apply those to how we understand the pathway of care that we deliver. Where are the bottlenecks? Where are the choke points? How do we overcome them? And I think slowly we're adapting to try and take some of those points on board about how we deliver services. So it's not just about gadgets or drugs, but it's about the whole systems management thing that undoubtedly we can learn from you lot. But we're trying to bring that in. I promise that we are. And there's some good examples of it coming from the NHS Innovation Centre, some very nice bits of work with Don Berwick from the IHI in Boston, blah, 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 in which, blokes like me are actually trying to unpick the pathway of care, redesign it, put it together, and, improve quality and do all that stuff.
Right, so the question there, and I think that'll have to be the last one. Because
okay, it will sound like an advert for my talk, but it was not meant to be that. Because what we've not mentioned in the last hour is the patient. And I actually think nowadays patients are drivers of innovation. If you look at social media, people are saying, I tried this drug, for example, things that are not very well defined at the moment, like fibromyalgia. I went on a social media site last night, and there are people saying, I want my doctor to prescribe this because on this social network, people are saying this is making a difference. I want this particular form of pain relief. It could be a device, it could be a drug. And I think the patient, and it's related to the citizen, the patient, I think is going to be part of the loop. And that's going to be a 21st century development fueled by social media, for example.
Can I add to that? Because I think it's essential there's a huge difference between patients being involved and patients driving it. Because I, as a consumer of Tesco's and Jaguar, behave totally different than as a consumer of healthcare. I would say things to Tesco's and Jaguar when they mess up my car that I wouldn't say to my GP. You know, I depend on my GP. I have a totally different relationship of trust and so on with my GP. I won't challenge them necessarily. So that means I, as a driver of innovation, is different, I think, fundamentally. I think it needs to be centered around patients, and the challenge is how do we get patients involved in this? To say patients behave like consumers and can drive it, it's not the same thing, especially in your case.
But it's changing, though. I agree, but I agree with it's changing, and this is, and you know, the Prime Minister is going to push that change and drive it forward. There's a website being developed like TripAdvisor called iwantgreatcare.com, in which you come to see me and you actually post care. He's got a bit of body odour, he's just come back from China, he's scrambling his words, he's incomprehensible with his Scottish accent, blah, 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 blah. And that's coming in, and that's the sort of thing that we're going to see much more of. And I think we've not got to be frightened of it, but responsive to it. And I agree, but it's a transitional thing, because at the moment, our patients are not. They're still slightly forelock tugging, and they're still slightly doctor. It's changing, and it will change in 5-10 years with the sort of drive that you mentioned.
Actually,
I agree.
It is only just 3 o'clock, so there's one more question. I think you had your hand up, didn't you? Yes. Where's the microphone? Oh, there. Right, thanks.
I'm working with Ryan on a startup from Oxford, and I also chair a small VCT group that finance small, innovative SMEs. And I think one has to look at it from the outside. There's been a lot of discussion around the NHS view of innovation, but for the people trying to break in, it's extremely difficult. I've now got groups of investors who say they will no longer support SMEs with the NHS as their main route to market. They just, if the business plan has NHS in it, dismissed. Now, that may be right or wrong, but that's the perception. The net effect is that the SMEs who are lurching from grant to grant or minor funding to minor funding will die, and you will miss the innovation completely. It'll just disappear. We haven't lost any investees yet, but it's getting pretty close. So my plea, is to try and find a route whereby you can get visibility of these innovations and get money to the small SMEs. It's all very well saying the banks need to lend. The banks will not lend to the SMEs. They will not do it. So they're on their own. They're talking to innovative clinicians often, but they often can't get through to the scale, the grants, or whatever. Or they get the grants and they come 6 months, 9 months, a year, and their debt is gone. Yeah. So it's somewhat of a plea that you've got a massive opportunity here to scale this innovation, and often you're missing it.
That's very disappointing to hear a comment like that, isn't it?
Isn't it?
That's not the intention. It was a plea.
But a statement. But let's carry that back to the corridors of power if we can. So Lionel and I were chatting at lunchtime. So we've got a Ministry of Defence that runs an Army, a Navy and Air Force, moderately well. But we've also got a defence industry, and somehow there's a sort of symbiosis between the two that works. We've got this massive organisation called the Health Service, but you're right, that there's no obvious way in for us creating or developing a health industry in the UK. I think business and Treasury are onto this, and it's like sort of persuading the banks to try and raise more money. I think you should write into Lansley, into Cable, and to Number 10, and it would resonate. Just at the moment, it would resonate hugely. And you're right, there's nobody paying much attention to that, because NHS is all about top-down centrism, big bang for your buck, doing sort of deals out there. And if Cable and all that bunch heard, from someone like yourself, that story, they'd want to respond to it. It would be very timely to write off angry of, you know what I mean? No, you're not angry, but you're slightly hurt. Wells. You're slightly hurt of Tunbridge Wells. And, yeah, exactly. But I sort of think supported by Geoff would be good.
There we must wind it up. I'm glad we did have that extra question, because it was important that we actually heard that, I think. Depressing that it was to hear it. Okay, thank you all very much, panel. Thank you for your questions in the audience. And